behalf of the BFE Project, it's a pleasure to have you guys here. There are a select group of students in this audience, and each one of you has expressed an interest in basically a wonderful Clark AU student named Joanna read the book and asked if there was something she could do to spread the word about Black maternal health. She couldn't be with us this morning, but she's going to be with us in some part. But basically what happened was we started to brainstorm and said, hey, what if we brought Black Maternal Health Week, we brought together a select group of students who might be interested in going into the field of OBGYN or women's health. And guys, that's why you guys are here, okay? So the reality is we have medical students, we also have fully trained experts in the field who've come and taken their time in order to share with you this morning. And first off, can we just give the students a round of applause? This is being live streamed, so if you're on live stream and on the virtual live stream, put your comments into the chat room, and we will basically, we have a board-certified OBGYN doc, Dr. Lewis, who's going to be helping to answer questions on the live chat, and we'll be pulling some of those questions to put in front of our panel list. What I'm going to do now is basically bring forward Miss Phoebe Brock to give a welcome on behalf of the medical students.
Thank you so much, Dr. Edmond, and good morning still. Good morning, everyone. Especially warm welcome. Well, I will start by saying my name is Phoebe Brock. I am a third-year medical student at Morehouse School of Medicine, and I'm also the president of the OBGYN Interest Group.
Good morning, everyone. My name is Kevin Borgella. I'm a first-year DO at PCOM, and I'm also the co-chair for Brothers in Medicine.
And good morning, everyone. My name is Joshua Hines, a current second-year medical student at Morehouse School of Medicine, residing from Chicago, Illinois, and I'm currently the president of our Black Men and White Coach chapter.
Thank you so much. And I just wanted to offer a very warm welcome to all of the pre-med students and medical students that are in the audience from Morehouse School of Medicine, Clark Atlanta, Spelman, Morehouse College, and everywhere in the AUC. I want to commend you all greatly for being a part of this conversation and having an early dedication to maternal health and really being wanting to be part of the conversation and all of the solutions that we're going to discuss today. And without further ado, I'm going to go ahead and introduce some of our esteemed panelists for today. I'll start with Ms. Shauna Cox, MSPH. She is the Associate Director in the Division of Reproductive Health for the National Center of Chronic Disease Prevention and Health Promotion, Centers for Disease Control and Prevention, the U.S. Department of Health and Human Services, and also a Clark Atlanta University graduate. Also, Dr. Michelle Mitchell, PhD, Associate Professor, Licensed Psychologist at Clark University. Dr. Tamika Alcia, MD, FA, COG, OBGYN, and Advanced Women's Care Center, Spelman College graduate. Dr. Michael Lindsay, MD, MPH. He is an OBGYN and Maternal Fetal Medicine Division Director for the Department of Gynecology and Obstetrics at Emory University School of Medicine, and he is a Morehouse College graduate.
I'm going to do real quickly, Chloe and Jada, can you stand behind me real quick? Because as we get this morning started, let's keep in mind it's all about the students themselves, okay? And basically, what I want to do very quickly is introduce Chloe, who's the president of the Undergraduate Psychiatry Association.
Welcome, everybody. Good morning.
And I also have to, definitely, this young sister right here is a dynamic assistant from Spelman. Come introduce yourself.
Hello, good morning, everyone. I'm Jada Phillips. I'm a graduating senior at Spelman College.
Thank you very much. I have to bring them up because Joanna is not present with us. But basically, just so I stick to the map, here we go. What I want to do and stuff is basically try and outline the urgency of the issue in a couple of slides, okay? Basically, I was minding my own business, working a regular day on a labor and delivery deck, and a young woman had a C-section. The C-section was uneventful. We went back and basically took her to the recovery room, and we had to take her back emergently to go back and save her life and almost give life, and basically give almost a 15 to 20 unit transfusion of blood, mass cow, almost like massive transfusion protocol to save a life. When I did the quality assurance write-up on the issue to investigate why we had to send a normally healthy person to the ICU intubated, struggling for a life, I was appalled to see that one of her number one risk factors for having a problem was the fact that she had brown skin and was having a child in America. And that's where I got introduced to the concept that, you know, of the high death rate for African American women. From there, we wrote a short story with my sister, and that's leading to this. And I hope that we learn something from this, and I hope it helps. Other than that, very quickly, I'm going to show you the urgency of the issue in a couple of slides. And this is for anybody who wants to simplify this thing. Number one, we can break it down into about 4 or 5 numbers, okay? The first number I want you to remember is 2, because the incidence for death for women across the board in America in the past 20 years has doubled, okay? So in America, the incidence for death for every woman having a child has doubled. But the appalling thing is that this is happening while in the rest of the world, the incidence for death has actually decreased by 39%, nearly 40%. So while America's death rate is getting higher, the rest of the world is improving. We're about 7 or 8 countries that are outliers, according to the World Health Organization, in terms of how maternal care is going on in our country. The other number that I want to introduce you to is, I mentioned, is 3. And that is that black women die at 3 times the normal rate during pregnancy, okay? There are a number of reasons, and we have the experts on the panel right here to tell us why. The other number that I try to focus people on is 60, because upwards of 60% of the deaths from mothers occur after that child is out. The mother makes it through the 9 months, delivers, and then for that next 6 weeks, there's almost like this red zone for them. But the reality is thanks to research coming from the CDC, now we know that we need to be watching these mothers for up to a year out from pregnancy, okay? So, and actually any death that occurs for a woman who's been pregnant, if they're up to a year out, it's almost, it's categorized a lot of times as a death of a mother. The last number that I wanted you to take home is 80%. And that is 80% of all the deaths and injuries of these mothers is 100% preventable, okay? And the numbers will say a lot, and that's all the numbers I'm gonna give. I'm gonna back off and turn this over to the excellent Dr. Maya Griffin. But before I do, I need you to understand that we're not just up here, you know how we have some of those chronic illness and chronic diseases where you know, there's nothing to be done about it. The reality is that this is 100% solvable. And in European countries, the death rate is actually 20 to 30 times less than it is in America. So this issue has actually been solved across America. And I think that's why, you know, I insisted on making sure that we have this happen. Okay, Maya?
All right, good morning, everyone. How are y'all doing? Good. First off, I want to thank you all so much for taking the time out to come on a Saturday morning to hear more about this crisis that we are facing in our that affects each and every one of us in some shape, form, or fashion. And I think the majority of you guys are all interested in going into medicine. And no matter what specialty or whatever field or aspect of medicine that you're going into, I think that each and every one of you can be a catalyst in making improvements and improving this crisis that we're in. And so I want to go ahead and get started with our lovely panelists here and having them give you guys some insights, and hopefully my prayer is that it sparks some innovative ideas in ways that you feel like you could get involved in helping this. Okay. All right. To start, what specific initiatives or programs does each of your healthcare facilities have in place to address disparities in maternal mortality rates?
Are we taking turns? Thank you guys so much for being here again. As the introduction, I'm Dr. Tamika C. My office is in the Stockbridge area, which is in Henry County. I am affiliated with Piedmont Healthcare. And I can tell you some of the things that Piedmont Healthcare is doing as a collective unit to try to help with this disparate issue that we have with Black maternal morbidity and mortality in the state of Georgia specifically, where unfortunately Georgia is very high on the list as far as maternal morbidity and mortality for women in general, but specifically Black women maternal morbidity and mortality. Dr. Edmond actually gave some excellent numbers. I'm gonna give a couple other numbers. The other number I'm gonna say is 80. There are 80 counties in the state of Georgia that do not have an obstetrician. Okay, I think there's 140 or so counties in the state of Georgia, so 80 counties without an obstetrician. There are only 15 counties that have one obstetrician or a women's healthcare provider in their county. My office is in South Atlanta, and unfortunately, that's where a lot of the, what I like to call medical desert land exists, where there's so many counties that don't have hospitals, don't have healthcare providers, and patients are driving long routes to get to a good healthcare provider that they feel like they can trust. So this is very near and dear to me because it's one of the reasons why I work in South Atlanta, because this is such a problem for just women in general, but specifically for Black women in the state of Georgia who have issues with access. I know we're gonna talk a lot about health equity, but we're still fighting issues with equality in the state of Georgia. So this is something that is very, very important for us to take heed to. So back up. Piedmont Healthcare, there's 23 hospitals in the Piedmont Healthcare system. We're continuing to grow. I feel like I go on the website and we've bought another hospital. It's growing tremendously fast. And what we're doing as a corporate conglomerate as far as the healthcare industry goes is that we're trying to put boots to ground when it comes to this issue with Black morbidity and mortality. As we know, the Black Maternal Health Week is April 11th through 17th. Piedmont Healthcare has a consortium of physicians that are across the Piedmont Healthcare system. We are called the Clinical Governance Council, for which I'm a part of. And what that Clinical Governance Council does is looks at these statistics, these things that Dr. Edmond brought up, the things that I brought up, and how we can combat those types of statistical anomalies that exist in our state. And what are we doing about Black maternal health? We are partnering with For Cure for Kids. I'm pretty sure some of you guys may know about For Cure for Kids, but for those that don't, I'll give a little bit of background. So Kira Johnson was a beautiful Black woman that was at Cedars-Sinai Hospital in 2016 and delivered her baby. And unfortunately met her demise via a birth death. She passed away from excessive hemorrhage. You may know that she is the daughter-in-law of Judge Hatchett, which is a very notable judge that's on television. But what they did after Kara's death was to really, really galvanize the community to say, hey, we need to really start paying attention to this. And this wasn't just an access issue, this was an equity issue, right? This is a person that had means, this was a person that had, good health insurance, this was a person that still died in a very well renowned hospital in our country, and what happened there. So with For Cure for Kids, they have done an excellent job with this group, and basically what they're doing is just getting out there, advocacy, outreach, actually doing community-based, having community-based resources. So we as Piedmont Healthcare are partnering with them. We actually have a walk today that is at the MLK Rec Center, and it's at 10:30 if anybody's interested in going after this. The walk is there, and then we're also going to be having a block party where we're going to have access to materials, access to things that you need for postpartum. There are giveaways. There are lots of things that we're doing, from the community standpoint, and this is one of the times where we don't need to take it step by step to solve a problem. We need to be solving the problem from all different facets. As my mama liked to say, don't burn the candle at both ends, but this is a situation where we burn the candle at both ends, right? So we galvanize the mom, we get, that information and that access to the mothers, but we also need to be looking at this from an institutional level. What happens to the mother when she physically gets in our hospital? That's what Piedmont Healthcare is at least trying to do, and I hope that the other healthcare systems are also doing the same.
Is the mic on? Can you hear me?
You want to trade with me, Doc? There you go.
So I represent a safety net hospital. I work at Grady. Dr. Griffin works there, and there are quite a few initiatives that we're doing, but I'm going to back up by first applauding you guys for getting up this morning to come and hear about this topic. And I think the other thing I want to say before I kind of give you what we're doing is that you're going to be the solution to this problem. And I think that that's really important. One of the other things I wanted to say as a preamble is Dr. Edmonds showed you about the increased rate of deaths in Black women in the state of Georgia. But I think you could easily substitute socioeconomic status. The poor women are the women who are dying. Black women just happen to be disproportionately poor. And so one of the things that we have to address is that we have to kind of improve our healthcare system. Specifically, what we're doing at Grady is if you look at the two main causes of death in Black women or women in the state of Georgia is related to bleeding after delivery, that's called obstetric hemorrhage, and hypertensive disease. And we have a vigorous program where we're trying to identify those problems and address them. We have a subgroup that meets looking at causes of obstetric hemorrhage, and that was the case that Dr. Edmonds gave you. And we're trying to recognize it and be more aggressive in terms of treating those patients. And in addition, we're following patients who have elevated blood pressures very closely to try to treat them to prevent them from having adverse outcomes. Those are initiatives that not only are happening in our hospital, but they're happening across the state. So those are kind of two examples of things that we're currently doing at Grady.
I will also add for Morehouse School of Medicine, we have the Center for Maternal Health Equity, where one of our principles is that we use translational science research to be able to not just do research to identify problems, but also how can we implement interventions and involve community to be able to make an impact for our patients that we're taking care of, just not only in the hospital, but also when they're at home, outside in their communities, especially in areas where it's a medical desert and they don't have care providers. So how can we better be able to use our community and being able to address these problems that we're facing in areas that don't have obstetricians and the care that everyone deserves to have? Okay. All right, well, I'm gonna, every time that we talk about Maternal Health Week, it's really important that we address that, Black women are at such an increased risk of death, but, delivery and birth can be something that's a very joyous, and it should be a joyous process and experience for everyone. What are some success stories or outcomes from your efforts to reduce Black maternal mortality rates have you guys experienced?
Is this on? Okay. So I'm the only non-clinician on this stage, and I took the route of public health, really thinking about issues from population-based approaches. And as mentioned, some of the programs that CDC supports are things like perinatal quality collaboratives. So those are things that you can get involved in facilities to really implement maternal safety bundles that address things like hemorrhage, address things like hypertension. And we've seen some programs, for example, in the state of Louisiana, when they implemented the safety bundle around hypertension, they showed that severe complications from hypertension decreased about 50% in Black women and 30% overall. So there are ways to think about how you can get involved in these initiatives as a clinician and also in the community to really understand what is the science and how do you bring that science to the care of your patients and improve outcomes and save lives.
Make a really good point about the safety bundles. Piedmont Healthcare has done a tremendous job with implementing hypertensive disorder safety bundles, maternal hemorrhage safety bundles as well. So I do believe that the safety bundle approach to kind of streamlining the process when you have a patient and identify a patient with postpartum hemorrhage or hypertensive disorders. And what we're talking about with these bundles, what's in them are medications and interventions that we perform within specific periods of time in order to decrease high-risk outcomes for those patients. So, you know, a hypertensive bundle has hypertensive medications that we give to the patient in order to improve blood pressure. And then we have, you know, scheduled medications and interventions that we do for postpartum hemorrhage as well. So just to clarify for the students what a bundle was.
I think the other thing to appreciate, and I'm thinking about this as I look at you because I'm thinking about the future, is that this problem in terms of Black maternal mortality is getting a lot of press, but it's not a new problem. And so if we look back, for the last 75 years, the disparity between Black and white death has been really constant, and it's been high. And the reason why I'm mentioning that is, as you look at this problem, I think you guys are going to be the ones who are going to solve it, because if a problem has been around for 75 years, we're not going to solve it in the next 5 years. There are a lot of steps that we can take to go in the right direction, but we're not going to solve the problem. And the other thing I wanted to mention as I think about this is that there have been a lot of studies that show that Black women in particular and Black patients do a lot better when they have a Black physician. The problem is there are not a lot of Black physicians. And so in terms of that being a solution, that's not going to be a solution, but that should be an incentive for you guys, if you're planning to be physicians, to become part of the workforce. Because in 1975, when I graduated from college, about 5% of physicians were African American. Fast forward, I've been out of college almost 50 years, and the same percent of African American physicians is about around 5%. So there's a lot of work that we need to do, and you guys are in a position to help us accomplish that.
Ms. Cox, from the perspective from the CDC, what are the most urgent priorities for addressing Black maternal mortality in healthcare policy?
Most important thing to understand is there's not one solution. There are a lot of different ways we need to come at this issue. There are the clinical issues that have been mentioned. There are the non-clinical issues, what we refer to as social determinants of health, issues around housing, issues around access, where facilities are located, how long it takes people to get the care that they need. There are also issues around coverage. Many states are now looking to expand Medicaid coverage. Before, if you had Medicaid and you were pregnant, after 60 days, you are cut off. So a lot of initiatives, and there's been a lot of energy into expanding that coverage to 1 year postpartum, so women have access to continue getting that continued care that they need throughout the year to address conditions that may arise, such as hypertension, mental health issues, depression. There are a lot of things that women need continued care and support for. So, again, there's not one policy or issue. I think there's just a lot of ways we need to think about it, and there's a role that everyone can play in solving this crisis. Okay.
Dr. C and Dr. Lindsay, speaking of social determinants of health, what are your particular institutions doing to address social determinants of health that can negatively impact long-term patient outcomes?
I'll start. I think one of the things to appreciate is up until 5 years ago, we didn't have a focus on social determinants of health. And I think it's become part of our routine history and physical exam to try to determine the social determinants. So I'll give you an example. If a patient doesn't have car fare to get to her prenatal appointments, she's not going to be able to come for care for the baby, and then you could predict that she may have an adverse pregnancy outcome. So one of the things we try to identify now up front is we would want to identify that and see if we could help patients so that they can get back and forth. And I think the other thing that I've also learned, and I've learned a lot kind of looking at this problem, I thought that the solution was if I became a better medical doctor and I did all of the things that a medical doctor could do, I could solve the problem. But the problem is a lot bigger than providing medical care. If patients don't have the ability to come to see you for care, they don't have the ability to eat, and you're talking about putting them on a special diet, then if you don't address those things simultaneously, then you're not going to have a good outcome.
I totally agree. And I can agree with the things that you're doing at your institution as well, as far as trying to understand what those inherent biases that we have when it comes to the social determinants that affect our healthcare, right? So, access. Once again, like I said, I work in South Atlanta, so access is a huge problem in the community that I work. Of course, like you said, not being able to physically get to appointments is a big problem. But also, too, just understanding cultural norms and differences and how those cultural norms affect how you show up to your doctor's office with issues that you have, right? If there's certain dietary things that are specific to your culture, then there are going to be some things that are going to be difficult for me to discuss with you if you get diagnosed with gestational diabetes and now I have to put you on a specific diet. So knowing those different social and cultural norms that are associated with our population is beneficial. And I think the best way of being able to do that is have more people that look like us in all aspects of that healthcare system, right? So my medical assistants, I have Black ones. My nurses, I have some Black ones. My other physicians that work for me in my office are also Black. Like these front desk workers, they're Black. So there's and of course I try to make sure that there's representation for everyone, but it's very important for the community that I serve that I have someone that looks like those people in the community that I serve, because that allows for there to be safety, that allows for there to be, it's just an assuredness that you have when you walk into an office. So having people in every single aspect of that patient's process as they're coming in for their prenatal care, allowing for them to feel safe so that they can discuss those social norms that are affecting them, right? Domestic abuse, which is another big, huge thing that's in South Atlanta for whatever reason, discussing that with patients and allowing for that to be a part of the healthcare process, and how is this affecting their care in general, and what's going to happen to them postpartum.
Yes. Can you speak to the domestic abuse component? Tess, when you mentioned the domestic abuse, one of the recent articles that came out showed that although we talk about the medical issues like hypertension, bleeding, sepsis, There's actually a killer that's of pregnant women in America that kills more women surrounding pregnancy and childbirth than all three of those combined, and that's actually violence. And that's why we have Dr. Mitchell here. Can you speak towards violence in the Black community and its impact surrounding safety, which is one of the #1 determinants of social determinants of health?
Good morning, thank you. So one of the things that we know is that African American women are greatly impacted by intimate partner violence. In fact, about 51% of African American female homicides are accounted for by intimate partner violence. And so when we talk about intimate partner violence, what we're talking about is not only emotional abuse and physical abuse, we're also talking about sexual abuse as well. And so it's very critical that African American women are screened when they're coming in to see their medical providers and also their mental health providers, because one of the reasons why African American women tend to die from intimate partner violence is the length of time that they remain in relationships. By the time African American women decide to leave those relationships is at the most volatile time where they're more likely to experience death. So it is a huge issue also because we know that intimate partner violence tends to increase from pregnancy all the way through at least 1 year postpartum. So those are critical times when we're talking about Black maternal health.
Okay. Because yes, as a clinician, Dr. C and Dr. Lindsay, when we're seeing patients, we're going in there with the mindset of we're addressing medical problems. But then when you're about to see the patient, your MA or your nurse is going to say, oh, well, she's involved in an intimate partner violent relationship. Or just the other day, I had a patient where her father, the baby, got shot in the head. So how do we best, and I would say it's hard trying to find the time to be able to address the medical problems that we need to address, but also be able to address the mental health of our patients, because that's also very important. How can we better involve psychiatry, psychologists in being able to address those aspects that are just as important as medical, physical conditions?
By forming relationships. One of the things I noticed that when I go to the gynecologist, those questions are asked. And so I think that OBGYNs are doing a great job of actually asking the question. And then I would say just the next relationship would be forming their relationships, because there are psychologists that focus specifically on behavioral health. Sometimes in larger medical centers, you'll see psychologists have their offices in close proximity. So it makes it easier for a physician to say, hey, there's someone I'd like to introduce you to. And literally, they can have someone walk them down the hallway. But also, too, just a phone call can be made, right? We love partnering with physicians. Also, inside of many hospitals, in the OBGYN departments, many hospitals or health systems have psychologists that are already working there. So that makes it a lot easier when a mom comes into the appointment, that they know that there's someone there who can talk to them about those issues.
Dr. Lindsay or Dr. C, how do you think that we can better incorporate psychiatrists, psychologists into our obstetrical care and even gynecological care of patients so that we're better serving the whole patient, not just medical problems?
Well, I think one of the things that we do have to do as obstetricians is pivot and shift our trajectory from thinking about postpartum depression specifically, right? So one of the issues is that we have a huge, support from our institutions about postpartum depression, which, can be anywhere between the first 4 weeks to 1 year after delivery. But we don't talk about antepartum depression. We don't talk about intrapartum issues that happen where, you know, fathers of babies are showing up to the delivery process and things are happening there, and there's so many different places and spaces that we need to be in order to advocate for the patient from a intimate violence, you know, perspective, or from a mental health perspective. We as physicians have to change our thought process about it and make sure that we're talking about it at our first visit, and make sure we're talking about it at our 4th visit and our 10th visit and postpartum and afterwards. I think just having those avenues in your office, I know for us, it's something big for me. It's something big for me. I am very much a clinician. I sit down in the room and tell me how things are going. And sometimes just asking the question will allow for the patient to open up. And it's important for us to, like I said, just make sure that we are targeting this topic multiple times through that pregnancy course in order to help the patient.
So I work in a safety net hospital, and we train residents and fellows. So we potentially have the ability to have a bigger impact. For example, we do about 3,700 deliveries a year, so we see a lot of patients. But the candid answer to your question, Dr. Griffin, is that we need additional resources. Currently, we have one psychiatrist that serves our prenatal population 1 day a week, and she can only see so many patients, and we have a psychologist who's available 1 day a week. These problems are 5-day-a-week problems, so if we only have them 2 times a week, you can kind of anticipate that it's something that we kind of have to prioritize. We have identified that, and we're addressing it. We're addressing that problem by asking for additional resources so that we can have additional personnel to be available to deal with our patients who have issues.
I think that's just so important, especially Dr. Lindsay, like, you know, we take care of patients who are in the hospital who have pregnancy complications and delivering early. And so there's also that component of, if you're having a baby, you know, you're going into pregnant, or you're pregnant and you're thinking, okay, I'm going to deliver my baby at 9 months. It's going to be beautiful. I'm going to have a water birth, delivered this way and that way, but you can't always anticipate the complications that are happening. And so you have to deal with the aspect of, you have a pregnancy complication. You have to also deal with the aspect of things aren't going according to your initial birth plan that you make. And also if you add onto the fact that you may deliver a baby preterm, and then your baby has to go to the NICU, and that's another psychological aspect that we have to keep in mind as obstetricians. Even if you deliver somebody at 38 weeks, you're telling a mom, oh, your baby has to go to the NICU, even if it's just for a day, 2 days, and you know, if it's 3 or 4 weeks, that's devastating. What are some other ways that we can try to better serve our patients in those circumstances, even from a psychological standpoint as well? And how can we also use community-based organizations to better provide social support for our patients?
Can you hear me? Okay. One of the things I think is ensuring that providers possess cultural competence. And what I mean by that is one of the things we know is that African Americans are sometimes misdiagnosed. And one of the huge misdiagnoses actually ends up being schizophrenia, a lot of times paranoid type. But sometimes diagnoses are missed. And that is because people may not recognize that sometimes symptoms may present differently. So there's recent research that shows that African American women sometimes do not present what we typically would expect in terms of depression. So we look for dysphoric or despondent, depressed mood, and hopelessness. And what we see in some African American women is irritable mood, women who are self-critical, We also see anhedonia, which is really when someone doesn't feel like they experience pleasure, or maybe the activities that they once enjoyed, they no longer enjoy them. And then also somatic symptoms. And one of the things that we know is that in people who tend to suppress their emotions, you'll see them have more somatic symptoms. And one of the things we know about African American women is that some African American women are very, very selfless, which means they will give to other people and not necessarily take care of their own health, not necessarily take care of their own mental health. And so that prioritization of others often leads women to try to suppress their emotions in an effort to be strong, right? And so if providers are not aware of that trend, if they are not asking those questions, they may not recognize the depression. It might not look like depression to them. And if they're providing a brief assessment, right, just a brief screener of depressed mood, it may not ask about somatic symptoms. It may not ask about them being self-critical. It may not ask about irritable mood, but it's likely going to ask about dysphoric mood or sad mood and hopelessness and helplessness and worthlessness. And African American women may not endorse those items. So the assessment itself may not be sensitive enough to pick up on the depressed mood. So I think that's one of the key things, is ensuring that providers are culturally competent. They understand how symptoms manifest, and also what are the ways in which African American women are living their lives such that they may themselves not be able to speak about what they're feelings, right? They may have to be prompted to talk about it. So that's what
I just wanted to piggyback on the whole concept of cultural competency. It's an evolution, and it's something that you have to consciously work on and learn. So you just can't make the assumption, because I'm African American and some of the symptomatology that's described, that I'm just going to be able to pick that up. And I think one of the goals that we have in training, and even after I haven't been doing this 50 years, but close to it, I'm still learning things. I'm learning something every day. And one of the things is, I think I am a more effective communicator with my patients than I was 10 years ago. And I think some of these issues that are being raised are really important, but it's not something that is intuitive. You have to work on it to try to help patients have their best outcomes.
I agree with what you're saying, because one of the other issues I think that Black women face that end up creating feelings of anxiety and depression is really feeling like providers aren't communicating with them. I think there's a difference when someone talks to you, but when they're really in a space with you and they're communicating with you. And some Black women end up feeling mistreated if they feel like they're being scolded, or they're addressing concerns and they feel like those concerns are being ignored. And it places them in a situation where they feel like their life might be at risk, their child's life might be at risk, particularly if they're at labor and delivery and they feel like no one's listening to their concerns. So it's like, it just places them in a situation where they don't feel like they have autonomy, they don't feel like they have control over their bodies, they don't feel like they have any sort of agency. And that's troubling, because we know there is a long history of that in our community, where African American women have not had control over their bodies. And so when you speak to cultural competence and talking about, really, it's not just knowing the symptoms, it is also in the way that you show up and understanding how your presentation impacts the patient that's in front of you. I think that was huge. Yes.
And that actually ties into the entire theme of the Quiltmakers book. And what we do in the Quiltmakers is basically show how a Georgia African American community works together to place a safety net under the women who are pregnant. So literally every time a woman has an issue, because they recognize that the woman who's just had a child, her voice may not be as strong as it needs to be, we basically have a midwife who comes up with a concept so that every time a black woman engages the healthcare system, she engages it in force with all of her community sisters behind her. And that's the whole purpose of the quilt making. Very quickly, I think we want to take some questions from the audience, and we'll take any questions. And let's see. Oh, there's some right here. Let's start.
Hi, yes. I just want to say thank you for coming and engaging in this discussion. My name is Kaylin Clay. Okay. I'm a current sophomore at Spelman College. I major in biology on the pre-med track, and I'm actually interested in becoming an OBGYN. But my question is, many women are unaware or misinformed on their reproductive rights. And so how can we as college students and as the youth best enhance reproductive literacy? That's it.
As a former Spelman grad, I know that there are some groups that are still on your campus. We still have SHAPE on the campus, correct? Oh yes, I helped start SHAPE 23 years ago, so I'm so very happy that it's still on the campus. So what you need to do is start becoming more involved in those campus groups that are on your campus. They're already resources. These are opportunities for you to be able to be at the forefront of what those things are for you. So reproductive rights and you know how that affects maternal health. I mean, that's the premise of those organizations that are on your campus. So being involved, spearheading, you know, yes, the organization may have had this as far as, you know, what it normally did, but spearheading new initiatives for the organization. That's where I think, you know, it kind of bodes a grassroots approach to, you know, a community problem. So getting started early in those groups on campus to help galvanize you to be effective and change. I'm glad it's still on campus.
I would also add that we're in the social media area, right? And so everybody's on Twitter, IG. I think the new thing is like TikTok. Everybody's like, I'm looking at TikTok. So go on TikTok and like make posts, like educate people, because there is a lot of misinformation that's out there. And so better educate people so that they have the tools that they need to better advocate for themselves so that we can make a positive difference and reverse these laws that are starting to negatively impact us.
I would say if you're on the campus of Clark Atlanta University, Dr. Kenika Bell teaches a class on Black women's mental health, and some of those issues are covered. I teach a class on social justice, and so some of these issues are covered, and we also encourage students to go out in the community and work with organizations. I believe Spark is one of the ones that deals with reproductive health, but I would also say, like you were saying, think of yourself as an advocate. Think about what you can do right now. We all have a sphere of influence. Each of you can get the link of the live stream, and you can send it out. You can post it on your social media. Some of you know moms, right? And you could be of help to a new mom. You can decide to babysit so the new mom can run errands, help with cleaning, help with folding clothes, being a listening ear, right, to prevent isolation. So think of your sphere of influence and the small things that you can do to move the needle, as well as large gestures.
Hi, I'm a first year women's studies major at Spelman. And my question is on like advocacy too, like removing negative connotations from like birth control and like condoms and like helping like women speak up against sexual assault, sexual violence, and like intimate partner violence. And I know it's hard because we're so young, and we're also such in close proximity with illustrious Morehouse College. And it's hard because your peers are like right across the street. So how do we like help our like Spelman students or female Clark students or even Morehouse College students who are facing these things as well? How do we help them get the voice to speak up? Because I don't want it ever to be too late that someone like dies or like things like that.
So you're saying, how do you use your voice to speak up?
Yeah, like how do we make like, is there like organizations, like do we make organizations on campus to make it so that these students have safe spaces to speak up? Because it's just like, I feel like, sometimes I feel like Title IX specifically doesn't like really reach out to us on like a, like how to like to speak to us like as students and not as like the big scaries, I guess, about these things.
So, honestly, I think that you all can use your available current student organizations. So for instance, last semester in my social justice class, the students decided that one of the things that they wanted to talk about was sexual assault and sexual harassment. And so we hosted events for women, female students. We hosted an event for male students. And then actually next Tuesday, we're hosting an event for students who are in the LGBTQIA plus community. And so the students really wanted to make sure that they included Title IX. And you all probably at Spelman have a student Title IX representative. So we invited our student Title IX representative at CAU, as well as a representative from the Gray Hospital Crisis Center. And then we also had students who also served as panelists. So we provided information as well as we had a question and answer session. So I just want to empower you as a student to use your voice. You are powerful. Use your voice, use your student civics. Yeah.
I can start. I will say when I was in medical school, I initially didn't know what specialty I wanted to do. When I was starting to decide, I initially thought dermatology. But when I did my OB rotation, I started seeing more patients that looked like me. And then also learning about all the statistics, how Black women were more at risk to have ovarian and uterine cancer, and Black women were more likely to have preeclampsia. And every time I read that, I was like, why? Why is this the case? And that is one of the things that sparked my interest and desire in wanting to do OB and specifically maternal fetal medicine because of all the adverse outcomes that unfortunately Black women are more at risk for. And so I wanted to be part of the solution in addressing that and trying to turn around those statistics so that we are not faced with all the health disparities that we're facing, unfortunately.
So my why is a little different. The youngest of 9 kids, and I grew up in a very impoverished background, but we had a large extended family. And I always had sisters who were pregnant, and I was in the house, and I was just intrigued by the process of pregnancy. And probably at the age of about 9 or 10, I said I wanted to be an obstetrician gynecologist. I'd never seen a doctor, and I didn't know what that term meant. But that was kind of my impetus for wanting to serve in healthcare. And the point of telling the story is that you can have a dream early. I didn't know what you needed to do to achieve that dream, but I was able to do it. And so follow your passions and your dreams, and sometimes they will occur.
I think mine is very similar to yours in regards to it was an early exposure to the field that galvanized me to want to be in women's health. At 13, my great-grandmother was diagnosed with stage 4 ovarian cancer. And she was the matriarch of our family, of course. And she got that diagnosis and passed within 4 months of that diagnosis. So at 13, I really knew that I wanted to be an OBGYN, despite not knowing how hard it was going to be to get into medical school, or how hard it was going to be going through residency, or any of those things. It was just what I knew. It was dropped in my spirit at that time that I should enter into women's health. And what was very interesting for me too, and I kind of picking up where Dr. Maya discussed, it was she was going to the doctor for all of these other things. You know, she had hypertension, she had diabetes. She was going to the doctor every 3 months. Not once did someone discuss with her her reproductive health after she went into menopause. So for me, it was not only did my great-grandmother pass from a cancer that could have potentially been diagnosed early, it was just, it was astounding to me that she was going to the doctor and no one picked up on the fact that she had stage 4 ovarian cancer. So for me, it was outrage. And also, too, how many other great-grandmothers are experiencing this. So that was what galvanized me to go into women's health and to be an OBGYN.
Hello, can you hear me? Okay, so for me, as a young person, I did not know what I wanted to do. I wanted to be a business person. I wanted to be an attorney. I wanted to be a teacher. I felt like I was good at every class. I was like, oh, what to do. And I had a friend who started college before I did, and she started telling me about all of her psychology classes. And I just got so excited. And then it hit me that all of the things that I was interested in was related to psychology. So I was the president of the Key Club, and on Saturdays we would work with children who had emotional and physical disabilities, and we work with this equestrian program. And I was a part of the program of helping children or students who couldn't read. Was a part of a literacy program, so I would help them to read. And I was a peer counselor, and I volunteered at a daycare center, and I realized, wait a minute, everything that I'm doing is related to psychology. So what I would say to you, if you don't know what you want to do, explore. Just explore things that are of interest to you, and then you will start to realize that the things that you're interested in, you might find an alignment with that in your future career. So don't be afraid to explore. Try some new things.
Hey, I'll build upon that. I had no idea what I wanted to do. I'm from Brooklyn, New York, was in Upward Bound, and they took us on a trip to the AUC. And when I came and I saw the yard, I was in love, and I was like, I'm going to Atlanta. And after I got to Atlanta, I was a chemistry major and graduated, worked in the lab, and realized I like to be around people. Couple different jobs, decided to go back to school to get my master's in public health, and studied epidemiology. Thought I was gonna do environmental health, but just so happened, there's a program called MHOTEP at Morehouse that partners with CDC, and I got a fellowship through MHOTEP while I was in grad school and got placed at the Division of Reproductive Health. And I've been there, I've had some other jobs within CDC, but for the most part, that's where I've spent most of my career in doing reproductive health. And what I realized was I was a doula before there was a term for doula. I was always the friend who brought the meals, who sat with in the hospital with folks while they were in labor. That was just naturally, my calling. So, being in this position, there's a lot of different ways that you can go. Like I said, just explore and kind of see where the universe takes you. It'll always take you in the right place. And, getting in these spaces and taking up spaces, our voices are important. I think we've all talked about cultural competency from a clinical perspective, or it could be something as similar. I'll talk about a campaign we've worked on and having to explain to the folks why that person did not want you to use their stylist to do their hair. Like, we don't let anybody else do our hair. And it was the difference between seeing somebody as combative versus understanding the culture. So those are the things that I think you guys really have an opportunity to play in this world.
Well, I was a little different. When I came out the womb, the doctor slapped me, and he said, "You're one of us." I'm just kidding. The reality is that I was exactly where you guys are, a number of years ago. And that's why, if I haven't shown anything, if our team hasn't shown anything, I hope we show that, by exposing you to the medical students and these experts on the panel, that this is 100% doable, okay? It's 100, every single person in here can become an MD, MPH, psychologist if they want to. The deal is your potential is actually there. So the reason that we have you here, and we didn't, necessarily invite 80,000 students, is that you guys are you're the core, you make up that future and stuff. And every single one of you, if you talk to the medical students and take good counsel, they will be able to coach you through and on to great things. But the reality is that, when you say, hey, what are the things we did to prepare? We did, number one, we did this. The time of having it at 9 o'clock in the morning, we could have had this at noontime for lunch. I'm gonna let you in on a secret. By putting it in the morning, we were able to differentiate the people who were serious about the field of medicine versus people who were just playing. As a result of that, one of y'all is gonna go home with a $300 gift certificate, okay, today. Don't know which one it's gonna be. We're going to select it, but the reality is that to the victors go the spoils. We extend the invitation. You may extend the invitation worldwide for people to come and share with experts and get networked with these 4 or 5 people on the stand. If you simply just network with them alone, one of them alone, you're already tied into Black excellence. They're already coming ready for you. So the reality is one of the main things you can do at the point where you are right now is to come meet a young sister like that. She's already leading, almost a lead researcher in a women's discrepancy, a women's health discrepancy initiative. For you, don't walk out of this room unless you get her information. Full professor at Emory, seasoned clinician in the Atlanta metro area, psychologist, academician who has ongoing programs in order to expand your mind and prepare you to be a health provider, and of course, a national leader at the CDC. This crowd isn't meant for everybody. So I know you guys looked and said, oh man, my friend said they were coming, there should be 500 people here. And when you go back to Spelman, Morehouse, and Clark AU, and you're in assembly, there are going to be about 100 other students that say they want to be doctors. But I want you to understand, it's you guys who got up in the morning. It's you guys that we're going to invest and pour into. You remember the AAMC when you registered? What happened 2 or 3 days ago? Y'all got a message to say, hey, just reminding you, don't forget to sign up for the AAMC virtual fair. We're going to look out after you guys, okay? I'm proud of y'all, all right?
So we're going to wrap this up. Again, just to piggyback on Dr. Edmond here, there's so much Black excellence in this room, and I'm looking at it right now, okay? Everybody share their social media stuff so that these young people know, oh, I feel old for saying that, so that everybody knows who to connect to. Please, we are all here. We all have been where you guys are. We are more than happy for you guys to reach out to us, to give you advice, mentor you, whatever it is that you need. We are here to get back to you all. I will start with mine real quick. My Instagram is Maya, MYAHM9. Dr. Lindsay?
I'm so old school, so I don't have social media, but I can give you my email, and I do respond to my email. So it's LINDSA without the Y at emory.edu. And I get literally 500 emails a day, so I will get back to you, but not immediately.
I have an office Instagram, so it's Advanced Women's Care Center, the full name is the Instagram, and anybody can find me on LinkedIn, Dr. Tamika C, and that's SEA, like the ocean, TAMIKA.
I'm going to do better in 2024, okay? I promise. Listen, I'm going to have a LinkedIn, an Instagram.
I gotta work on my LinkedIn too, so it's okay.
I I have an email address for you, mmitchell@cau.edu. Yes, @cau.edu.
And I think you guys already signed up, so we're already linked and stuff. Very quickly, we're going to go to the take-home. When we got this together, we wanted to do more than just outline the urgency, discuss the problem. We wanted to present somebody who had the solution. Let's all, we're going to step down from the stage and turn it all the way over to Ms. Cox and lead us on home.
All right, thanks, Dr. Edmond. So today I want to talk to you guys and share with you the Hear Her campaign. And it's really a tool that you can be aware of both in your professional careers as they grow and also just as members of the community as you're dealing with family members and friends who are going through the journey of pregnancy. And one thing we learned through some of our data is that there was really a need to educate about the urgent maternal warning signs that indicate when a person should get medical care right away. We also came to understand that healthcare providers play a key role in listening to women and addressing their concerns. So this campaign started in August 2020, and so by raise of hands, has anyone heard of the Hear Her campaign? Okay, so I guess everyone follows into the no bucket. So I'll tell you a little bit about the campaign. So the Hear Her campaign, again, was raised to raise awareness of the urgent maternal warning signs and to encourage support systems and healthcare professionals to really listen when a pregnant and postpartum person expresses concerns. One of the slides that Dr. Edmond showed earlier was Dr. Shalon Irvin. She actually worked at CDC, and she did everything right. She was well educated, had her PhD, and when she became pregnant and she had her beautiful daughter Saleha, she started having symptoms. And she went to the doctor over 7 times complaining about swelling, headaches, high blood pressure, was not listened to, and eventually the last time that she went home, she passed out in her closet and never regained consciousness. There are other stories, for example, was shared, Kira Johnson, obstetric hemorrhage, husband Charles wanted to get her help, and they were not listened to. So that was really the onus for this campaign, was really emphasizing the need to listen to patients. So not only pregnant and postpartum women understanding when something is wrong, their friends, their family members, anyone that they're interacting with, really understanding the role that everyone has to play in really listening to pregnant and postpartum persons and helping them get the care that they need. Next slide. So the bedrock of the campaign are testimonial videos. And you'll see here the pictures of the 11 women who experienced pregnancy-related complications and conditions, where they're talking about their experiences and how they got help. Allison Felix, renowned track and field athlete, is one of our spokespersons, and her story was also captured. Okay, you guys can hear me with that? Good. So now I want to play a 30-second PSA for you guys, just so you can get a feel of the campaign. So if we can switch to that YouTube video.
They're the ones she confided in about her change in vision and headache that wouldn't go away. He's the one who really listened when she said that something just didn't feel right. When she had chest pains a few weeks after delivery, she's the one who insisted on admitting her to the hospital. Too many women die from pregnancy-related complications each year in the U.S. Death can occur during and up to a year after pregnancy. It doesn't have to be that way. Most deaths are preventable. Know the warning signs, hear her concerns. You could help save her life. Learn more at cdc.gov/hearher.
where if a woman is experiencing these symptoms, she should get care right away. We also have resources for providers, really helping focus in around listening to the patient. You can go to the next slide. And I'll try to kind of, yep, and here are the warning signs, and they're kind of laid out here. There are 14 signs. These are not all encompassing of all things that can go wrong during pregnancy, but again, really kind of trying to boil it down to the top 14 of things to really think about, such as fever, extreme swelling, chest pain. Next slide. We have materials in a lot of different languages. Again, going back to the theme of cultural competency, these are all the languages some of our materials are presented in, and we have used these materials in a number of different areas, for example, the Clarkston area when we're working with different refugee communities. Next slide. There are conversation guides and palm cards, so please, those who are practicing, you can order these free of charge. Next slide. For those who are social media savvy, there are lots of shareable graphics, things that you can share from Twitter, from X now, Facebook, Instagram. There are a lot of materials and free things to download. Next slide. And again, really emphasizing these tools for healthcare professionals and things that you can incorporate into your medical school education. Next slide. We have testimonial videos from providers where they're talking about their experience providing care and listening, addressing unconscious bias, is also some of the materials that we produce as part of the Hear Her materials. Next slide. And again, a suite of tools, things that we've talked about, such as the maternal safety bundles. There are things you can read about on the Hear Her campaign. Resources for being culturally competent, listening, and really how do you have that engagement. You know, one thing we have to acknowledge is that there's a kind of a power dynamic when it comes to the provider and patient relationship. And so really, as kind of mentioned by some of my panelists, understanding how you show up really has a big difference in regards to how women are sharing their stories with you. Next slide. Again, next slide. Here. And there are a lot of ways that you can even use these campaign materials. Like I said, there are pre-written articles. So if you are part of a newspaper group, a group that has newsletters, we have pre-written articles that can be plopped into newsletters. The PSAs and videos can be shared at conferences, community events, and meetings like these. Handouts are available and can be ordered for presentations, exhibits, and again, using these materials to counsel your patients. And next slide. And so I'll stop right here. I know folks, the QR codes make it real easy to get to the website and download these materials. So I'll leave this up for a second so folks can go ahead and explore that. And again, if you miss it, it's also on the banner that we have there. You can order free materials, download materials. We have a Facebook page, CDC Hear Her. The division has an X page, and if there are any questions, you can always email hearher@cdc.gov to get more information. So again, Dr. Edmond really want me to just bring this to you guys as something that you can use now as you are supporting the pregnant and postpartum persons in your community, raising awareness, sharing awareness of these materials, and really helping being part of the solution to address maternal health. Thank you.
In closing, number one, can we give our panelists a round of applause? And then we have some giveaways for the panelists. Each one of you has received a copy. Raise your hand. There you go. All right, of the book. Okay. The bottom line is, I just want to very quickly get you to stand up and repeat something after me, okay? It's a phrase that we use with the Dream House Make a Difference Foundation. When we had our first meeting about 4 years ago, and Candace and Zaja decided that they wanted to do things to help the Atlanta community, the world started to change and open up, okay? So if you repeat after me, I'll teach you the phrase. And whenever things look crazy and you can't see where things are going, I want you to remember this phrase. Just say, I will move like something is about to happen. Let's say it all together. I will move like something is about to happen. Now, I want you to say it louder as if one of y'all gonna win $300 in the next 30 seconds. Let's say it. I will move like something is about to happen. Okay, let's stand up. I'm gonna have you say it one more time. And then say it with this vigor, and then I will let you know which one's gonna be happening with that $300. Deal. On the count of 3, I will move like something is about to happen. Now we talking. Absolutely. The person who won the $300, our winner in person is it Jaisha Williams? Jaisha Williams? Who's that? Come on up here. All right. And then online, the person who won is Charlotte Hopkins. Charlotte Hopkins will be sending you a $300 gift certificate. So in closing, I hope you guys see that, number one, you have a vibrant group of alumni who are willing to support you. We're going to close out, let you guys network. We have a rolling out video team that's going to be interviewing you guys just about the issue and to keep you motivated so you can reach out and motivate other people in the community about going into this field. This does not exclude the midwives. It does not exclude the doulas. It does not exclude the extensive group of public health experts who are helping to address this problem. But just for this morning, we wanted to focus in on those people who were pre-meds or looking towards going into medicine, okay? Amen. I want to thank y'all. We'll keep you in prayers. Network, network, network. God bless you all.